Nick Majerison here, welcome to Top Med Talk. And today's Top Med Talk is Part 1, ASA 2018 San Francisco, Enhancing Recovery from All Surgery, Cardiac, Spine, C-Section. It's Part 1 of the conversation, Part 2 will follow tomorrow. Make sure you listen to the end of today's podcast so you can find out how you can download the entire back catalogue of Top Med Talk. All the podcasts we've done so far could be available to you. That's coming up after you have a listen to this.
Top Med Talk.
Alrighty, and welcome to Day 3 at Anesthesiology 2018 Top Med Talk. Here we are at the Smith's Medical booth in the Connection Center, booth 1519. We kicked it off this morning with Monty talking about what we've been doing and kind of what's going to happen today. Morning, Monty, my partner in crime.
Morning, Desiree. Morning,
yes.
Desiree. Wasn't last night great?
It was. It was fantastic.
So we had that educational symposium where we did those 2 live broadcasts with a really engaged audience, 200 people. We've still got a rack of Slido questions that we'll get through later on today because we promised those people. But really, really great engagement talking about pain management, but particular regional with
Vincent Chan.
And then we talked about some more, and we're going to discuss it again in a second, I think, about cesarean section obstetrics and enhanced recovery with Elizabeth Sherrill.
Which
was really Sherrill.
I'm working on it. It's Sherrill, but Elizabeth, if you're listening, I'm practicing.
And it was great. It was funny. It was amusing.
It was, yeah. It was nice after a day of meetings, I'm sure, to do something a little bit different for the guests that we had last night and not to have to look at slides all night long. There was no slides shown by a presenter, which was great. And we filled the time without a problem. Yeah, we could have kept going, in fact.
And it was amazing still how much time we can spend talking about NPO.
Oh my gosh! Yeah.
How long is a safe period of time? How much can you drink? Does the stomach empty? It's going to run and run. It's good.
Forever.
Been going since the century before last.
Yeah, I was just going to say we've already been talking about it for a while. So that leads us actually to our very special guest that we have joining us this morning. It is Dr. Laurent Bollag, University of Washington Chief of Obstetric Anesthesia and Associate Professor of Anesthesia and Pain Medicine. Laurent, if I may, thank you so much for joining us.
Thank you very much for having me.
Good morning.
Good morning.
So we were actually talking to an obstetrician last night, and there were a lot of questions that we got during the meeting that were more specific to the anesthesia perspective, obviously being an anesthesia at the ASA meeting. So we're going to go through some of our Slido questions. But just to kind of kick it off here, I would like to know kind of what your perspective is for enhanced recovery after surgery or enhanced recovery for the obstetric patient.
Thank you very much for having me.
Yeah.
Enhanced recovery for cesarean section. Cesarean sections were relatively latecomers to the enhanced recovery protocols, which are widely implicated now, right? The problem with enhanced recovery for cesarean section is that the usual aims for or outcomes for enhanced recovery protocols, namely lengths of stay, that's a bit of a difficult one for the obstetric population because we're dealing with the baby and the mother. And especially in the United States, where the social system is aligned in a way that pretty much after a young family is discharged from the hospital, they're pretty much on their own compared to, for example, in the UK or in Europe. Using that as a metric for a successful enhanced recovery could be a problem.
So, Lauren, if I may, I think that's been a recurring theme for everything we've discussed about patients in the US having babies, is enhanced recovery should really be what it says on the can. You're enhancing the recovery.
Right.
And I think that's been misinterpreted as how quickly can I get you home.
Yeah.
The how quickly you can get home is a surrogate of the fact that your recovery's been enhanced. And if you choose to go home and you can go home, you could go home more quickly if the baby's ready. So I think we've all agreed that the target is to get mum fit for discharge as quick as possible, but not necessarily out the door. Is that fair comment?
I think that's precisely it. And the provision of anesthetic care for C-section, for example, is pretty much, there's a lot of evidence out there how to provide anesthesia for C-sections in order for the mother to be very quickly, mobile, have small side effects, have quickly ready to be able to take care of the baby. That is one of the main prerogatives of obstetric anesthesia. So obstetric anesthesiologists for a long period of time have already been trying various ways to optimize the mom, that she can immediately take care of the baby. So ERAS covers a lot of those elements.
Yeah. I mean, you would think that this is a patient population that we would want to focus on. I mean, isn't this a large surgical population in the U.S.?
It is a very large surgical population. I think we have over 1.3 million cesarean deliveries in the U.S. That's about a third of all deliveries in the U.S. So we're talking about a very large population. But the good thing is, most of the time we're dealing with a very young and healthy population.
Yeah.
So we're able to really have a great impact in their recovery, because usually medical comorbidities slow down recovery, and that is not necessarily present in that population.
Yeah, I guess you can't count a newborn baby as a comorbidity, but
no.
Sometimes I feel like it sometimes.
It's a pleasure.
Yes, of course.
Ron, we were chatting before we started. Your career started overseas,
right,
and transited through the United Kingdom. So where did you start, and what brought you to the UK, just briefly? Because we're going to reflect on some of the issues that are different transatlantically.
So I did my medical training at the University of Zurich in Switzerland, and I did 1 year actually in the UK as a medical student in London, St. George's Hospital in Tooting. Then I finished my medical degree in Zurich, Switzerland, and then I came to the US in 2008 to Seattle. Yeah.
So one of the things we picked up in the previous discussions, which I hadn't really appreciated before, even though I did live in the US for a while, and one of our children was born in the US, is the difference in the support you get when you go home.
Right.
So could you reiterate that for us?
So the big difference is that in the US, once you leave the hospital, there is no infrastructure available which can support the newborn or the new mother. Basically, it's everybody, each for him or herself, really. You have to organize it yourself. If there is a lack of an organized structure, the weakest of the society will fall through the gaps, right? Whereas in Europe, or at least I know it from the UK and from Switzerland, there's a very rigid infrastructure available which is going to take care of mom and baby even after you leave the hospital or the acute care facility.
Because we're lucky enough to have 4 beautiful children, 3 of them born in the UK, and now I think back on it, the first day you're out of hospital very, very quickly.
Right.
The first day and subsequent days until it's decided that you don't need the visit, you get at least 1 visit a day from a community midwife. At least 1. And they're there on the first day before the sun sets, and part of it is checking that you, the dad, are fit for purpose, or whoever it is that's helping mum, or the relatives, and the heating works, and the baby can get on the breast and all those things. But what I'm hearing is, Desiree, that just hasn't happened.
No,
yet.
absolutely not.
I'm sorry to bang on about this point.
No, unless you spend your own money to do that. And those services are, they're fairly expensive. And obviously, most people cannot do that if it's not provided by the hospital facility or by a community service, which I believe there are some out there, but not really.
It's very regional. It depends really on the region. And the problem is that protocols like this could be misinterpreted by entities, which are more focused on rapid turnover and financial gain, to discharge possibly, women which potentially could benefit from a little bit longer health care. So one of the future avenues to go would definitely be creating sort of like a post-acute care setup where women and moms can reach out and get information. And one option for this would be, for example, telemedicine. The US is a huge country, right? And distances are vast. So if you could call in, or if you had a little, a video call with an expert who could answer your question, I think that would fill a great need. And I think that's one way this could go. Yeah.
So that's a very clear, distinct difference. We've agreed that the objective is to get mum as fit as possible, as quick as possible, to look after baby, but not necessarily in the US to get them out the door. The other recurring theme has been, pain management is a core component of obstetric practice.
Right.
In a way, it's led the rest of us towards the greater use of regional epidurals, spinals, blocks, etc. But the other big stark difference was the high use of opioids here and people going home with opioids compared to, I think, what I've been used to elsewhere. Has that changed a lot in your practice recently, or is it?
So, obstetric anesthesia, evidence-based obstetric anesthesia, has since basically the year 2010, where we looked at various intrathecal opioid doses of long and short-acting opioids, and try to understand how long will that analgesic effect last, has sort of like modernized post-cesarean analgesia. And we've realized that an intrathecal long-acting opioid, for example morphine, will provide prolonged post-cesarean analgesia, which even is superior to analgesia provided by a regional block, for example, TAP block. And putting blocks like this sort of like on the reserve bench if you couldn't give intrathecal opioid. So you have this main theme is the intrathecal opioid analgesia. And then you add Tylenol and NSAIDs as additional analgesics. And by sort of like regulating all these non-opioid analgesics, giving them in a scheduled way, and putting the opioid as a PRN medication only, per patient request only medication, we were able to reduce the use of opioids a lot. In Seattle, what we have done now to sort of like counteract the trend in this great opioid epidemic which is happening right now, we're limiting the amount of opioids which are dispensed to patients before they leave the hospital. As a matter of fact, I think at the moment, don't quote me on that, I think we're giving just 30 pills of oxycodone, but we used to give, I think, up to 200 pills of oxycodones. And we do know that if you give more, if you dispense more pain medication, people use more.
Yeah.
And we also know that there's more and more evidence that if you integrate the patient, explain how to do the pain management in the best way, and people are very receptive and actually use less pain medications. So,
any sense of how many of those 30 tabs get used? Because that still sounds like a lot to me.
I know. There is some suggestion that some people just use a few, 3, 4 tablets. It depends a little bit. If somebody used already a lot of pain medication in the postoperative period, especially opioids, chances that these patients will require more opioid pain medications, there seems to be some evidence for that. So if patients use very little in the immediate postoperative period, then it makes probably little sense dispensing a lot of pain medications.
One thing we heard from Elizabeth last night that I think was really interesting and we really should consider is a diversion program. Do you have anything like that where if 30 pills are dispensed and they're not taken, they can bring them back to you? That's what they started at their facility. I would think that's kind of brilliant.
So part of our ERAS effort have led to various information for our patients and PowerPoints and documents to download. And one of the information we provide is if you don't use all your pain medications, please return them to the pharmacy. I'm not sure how realistic that is, given that a lot of our patients come from hours and hours of drive away. But I think we're creating an awareness that there is a need for these medications to be safely returned or
their 6 weeks checkup would be great just to say bring it with you.
The 6 weeks checkup is almost too far away. It's almost too far out. Yeah. But we're working and we are looking at different methods how to really optimize the dispense, the amount of opioids we're dispensing, and who knows, maybe another outlook into the future will be an opioid-free post-cesarean analgesia, very much how we already know it from other countries. Yeah.
Top Med Talk.
I mentioned at the start our back catalogue of over 300 podcasts. You can download all of these completely free today. Top Med Talk is committed to open source publishing and will remain so for all new material. As we continue to grow beyond our expectations in subscribers and engagement of thought leaders around the world, we will be diligently working to enhance the experience of our listeners by creating a back catalogue, a highly curated collection of our podcasts, advanced search options and special bonus features. This will be available through our new app at a fee. So we encourage you to download all of the podcasts right now. It's completely free through to the end of this month and contains some absolute classics from some of the greats. Enjoy.